Let's go ahead and jump right in here. So a couple of this discussion topics that we're going to go over this morning is we're going to really focus on some of the telehealth expansion. So what's staying in terms of services that were added through the public health emergency, and what's going as soon as the either end of this year or the public health emergency declaration has expired. We're then going to talk a little bit deeper into what some of those impacts are, not just to some of the services that have been added to the telehealth covered list, but then also there are some regulatory requirements that have been waived under the public health emergency. So we're going to talk about some of those. And then lastly, we're going to get into some COVID-19 vaccine billing. I'm going to throw out a lot of detail here. My slides are pretty rich in content, especially when it comes to the vaccine billing. So you should be able to grab this information and then just start putting it on your claims. So let's move forward here. So before the COVID-19 public health emergency, approximately 1,500 fee-for-service beneficiaries each week received a telemedicine service. Services allowed as telehealth were about 107, and the patient receiving telehealth services was required to be established. Additionally, there were strict guidelines for organizations to qualify as either an originating or distant site provider. So fast forward into March of last year, and as we know, a lot of things changed. America has experienced a change in the way that we provide telehealth services to patients. Since the beginning of our public health emergency declaration, CMS has enacted several waivers, temporarily relaxing several regulations in an effort to increase telehealth and reduce in-person clinic visits. So under these waivers, we have seen site restrictions waived to allow RHCs and FQHCs to provide services and bill as a distant site. CMS also relaxed the requirement that the patient must be established. 144 services were added to the telehealth list to allow for safe access to important healthcare. These services included emergency department visits, initial inpatient and nursing facility visits, and discharge day management services that will be covered by Medicare through the end of the PHE. And as a result of these waivers and added services, preliminary data show that between mid-March and mid-October of 2020, over 24.5 million out of the 63 million beneficiaries and enrollees have received a Medicare telemedicine service during the PHE. So published on December 1st of last year is CMS's calendar year 2021 Physician Fee Schedule Final Rule, which expands the coverage of Medicare telehealth services in several ways. The regulation finalizes policy which will result in Medicare covering 251 types of telehealth services as of January 1st, so this year. These services fall into three groups, and based on when the Medicare coverage of these services are due to expire, that's the group that one of these will fall into, each service, if you will. This final rule delivered on an executive order focused on improving rural health and telehealth access by adding more than 60 services to the Medicare telehealth list that will continue to be covered beyond the end of the PHE, and CMS will continue to gather more data and evaluate whether more services should be added in the future. These additions allow beneficiaries in rural areas who are in a medical facility, such as a nursing home, to continue to have access to telehealth services, such as certain types of emergency department visits, therapy visits, and critical care services. Additionally, CMS did announce a commissioned study of its telehealth flexibilities provided during this COVID-19 public health emergency. The study will explore new opportunities for services where telehealth and virtual care supervision and remote monitoring can be used to more efficiently bring care to patients and to enhance program integrity, whether they are being treated in the hospital or at home. So let's go ahead and dig into these three groups. So CMS added several services permanently to its Medicare telehealth services list, which is shown here as Group A. This group represents 45% of the telehealth services, or 112, that will be covered by CMS as of the beginning of this year, so January 1st, and also includes services such as group psychotherapy, neurobehavioral status exams, short home visits, and visit complexity code G2211, which is inherent to evaluation and management associated with medical services that are part of ongoing care related to a patient's single serious condition or a complex condition. CMS classified these services as Category 1 under a streamlined review process based on their determination that these services are sufficiently similar to services already on the list of Medicare telehealth services. And for home visit codes, and that's your 99437 through 438, the patient's home can serve as a qualifying originating site when the patient is being treated for a substance use disorder or a co-occurring mental health disorder as permitted by the Support Act. So based on trending in 2021 estimates, the majority of Medicare telehealth volume is likely to occur with services within this group. CMS also finalized its proposal to allow all Category 3 telehealth services added to the Medicare telehealth list during the public health emergency to remain on the list through the calendar year in which the PHE ends. This group represents 23% or 57 services of all telehealth services covered on January 1st of this year and includes services such as emergency department visits, all levels, all levels of physical therapy, occupational therapy, and speech pathology, hospital day discharge management, and critical care services, just to name a few. CMS's rationale for covering these services on a temporary basis is to gather data to assess if these services should be covered on a permanent basis starting next year in 2022. Under this last group, CMS will cover a large group of telehealth services only until the PHE expires. This last group represents 33% of all telehealth services covered on January 1st of this year and includes services such as audio-only telehealth visit codes, initial hospital and nursing home visits, and home visits for new patients. You can review the full list of temporary codes allowed during the PHE by visiting the 2021 Medicare Telehealth List of Services, and then filter that list for items that have been described as temporary addition for the COVID-19 pandemic. CMS also finalized in its recent regulation coverage enhancements for other Medicare virtual care services, such as remote patient monitoring in patients' homes and quick clinical visits, which are described as communications technology-based services, or CTBS. CMS's policy changes are expected to remove some of the barriers providers face in offering remote patient monitoring and CTBS to their patients. For example, for remote patient monitoring services, CMS will permit patient consent to be obtained at the time of service delivery and will permit auxiliary clinical personnel to provide RPM services. On an interim basis, which in this case means for the duration of 2021, CMS created HCPCS code G2252 for extended services delivered via synchronous communications technology, including audio only. One example of that would be virtual check-ins. The service is considered to be a communication technology-based service and is subject to all the other requirements of the CTBS. G2252 is crosswalked to CPT code 99442 for reimbursement purposes, making its reimbursement higher than the current, more limited duration virtual check-in code. The code is intended for situations when the acuity of a patient's problem is not necessarily likely to warrant an in-person visit, but when additional time is needed to make this assessment. Because it is a CTBS, or communication technology-based service, the traditional telehealth service location restrictions do not apply, which in part means G2252 can be used regardless of the patient's geographic location and regardless of whether the PHE ends prior to the end of calendar year 2021. Thus, while the audio-only telehealth codes currently approved subject to our Section 1135 waivers may only be used during the PHE, this code would extend beyond the PHE. The communication technology must be synchronous and is subject to the same billing requirements as the other virtual check-in codes. And CMS is considering whether this interim policy should be adopted permanently. For Incident to billing, the formal definition of direct supervision requires the physician to be physically present in the office suite and immediately available to furnish assistance and direction throughout the performance of the procedure. Under the public health emergency temporary waiver, direct supervision can be met if the supervising physician is immediately available to engage via interactive audio-video. However, the physician's real-time presence or observation of the service by way of interactive audio-video technology throughout the performance of the procedure is not required. CMS has announced that this definition will be in place until the end of this year or the end of the public health emergency, whichever is later. The duration of this change is time limited because CMS has concerns that widespread direct supervision through virtual presence may not be safe for some clinical situations, and overutilization could occur. CMS will study and collect data on whether this change may be appropriate on a permanent basis after the PHE expires. And lastly, CMS is reducing the frequency limitation for coverage of subsequent nursing care services furnished via telehealth from once every 30 days to once every 14 days. The original 30-day restriction was due to concerns on the acuity and complexity of nursing facility residents and to ensure nursing facility residents have frequent encounters with their admitting practitioner. CMS was persuaded that the use of telehealth is crucial to maintaining continuity of care in nursing facilities and to honor the independent medical judgment of treating clinicians to decide whether telehealth versus in-person care should be used, depending on the needs of each specific resident. Frequency limitations have already been temporarily waived for the duration of the PHE, but this new rule change is permanent effective January 1st of this year. So now let's talk about the impact to telehealth when the public health emergency expires. As we discussed earlier, telehealth services in Group 3 will cease to be covered after the PHE expires. But it's important to remember the expiration of the PHE will have other critical implications for services in Groups 1 and 2. While the services in Groups 1 and 2 will still be considered covered by CMS, once the PHE expires, providers will once again face restrictions on how telehealth is delivered. Audio-only visits will no longer be covered, requiring telehealth visits to be conducted in an audio and video environment. Site restrictions will also be imposed once again, impacting both originating and destination site billing. Patients' homes will no longer be covered as originating sites for most services, and RHC and FQHCs will no longer be able to provide and bill for services as a distant site. Telehealth will once again be limited to only established patients. New patients must have at least one in-person visit with a provider before being eligible for telehealth. So why is this happening? These Medicare telehealth limitations are written into statute in Section 1834 of the Social Security Act, and CMS lacks the statutory authority to modify them. It was only through its waiver authority under Section 1135 of the Social Security Act that CMS could temporarily remove these limitations during the PHE. Therefore, removing these limitations to Medicare telehealth coverage requires Congress to pass legislation modifying Section 1834 of the Social Security Act. So let's pop into vaccines. So let's briefly talk about what is emergency use authorization. So it's a mechanism to facilitate the ability and use of medical countermeasures, including vaccines, during public health emergencies such as our current COVID-19 pandemic. So under emergency use authorization, the FDA may allow the use of unapproved medical products or unapproved uses of approved medical products in an emergency in order to diagnose, treat, or prevent serious or life-threatening diseases. This criteria includes that there are no adequate, or excuse me, certain statutory criteria, I'm tripping up on my words here. Certain statutory criteria must be met, and this criteria includes that there are no adequate, approved, and available alternatives, and clinical trials have been conducted according to the rigorous statutes set forth by the FDA. Taking into consideration input from the FDA, manufacturers do decide whether and when to submit an emergency use authorization request to the FDA. So we've seen a lot of information in terms of an emergency use authorization for the vaccines on our next slide here. So first on the list to be granted emergency use authorization was Pfizer, who received their EUA from the FDA back on December 11th of last year. 7 days later, on the 18th, Moderna received their emergency use authorization. As most of us know, both Pfizer and Moderna require 2 doses, with the interval between doses set at 21 days for Pfizer and 28 days for Moderna. In addition to the vaccine code, each has a unique administration code that differentiates between the first and second dose. So be sure to have your charge master updated. Janssen, or more widely known as Johnson & Johnson, received their emergency use authorization this year on February 27th. And unlike the last two we discussed, this is a single dose vaccine. So there is no need to schedule a second appointment. And just like the other two EUA approved vaccines, the Janssen vaccine has a unique administration code. Lastly, we have AstraZeneca, which is another two-dose vaccine, but is currently not available for use in the United States. So in terms of vaccine documentation, each recipient's vaccine should be recorded in the patient's record within 24 hours of administration and should also include the vaccine, the date of the administration, the type of vaccine or the manufacturer, lot number, site and route, name and title of the person administering the vaccine. The vaccine record card given to the recipient should include similar information. You have to have your date on there, the product's name or manufacturer, lot number, location of the administering clinic, as well as the name of the healthcare professional. In terms of vaccine reporting back to the state, all COVID-19 vaccine providers must report vaccine inventory daily to Vaccine Finder. That will include inventory reporting, and this vaccine finder will also share vaccinating locations to the public should someone want to look for a place where they can receive their vaccine. Providers also want to report the vaccination to the appropriate state and local immunization information system. The Vaccine Finder website helps people find the information about providers who offer select COVID-19 vaccines. Vaccine Finder also allows healthcare providers to list their vaccination locations in a centralized, searchable database and to track vaccine availability. Okay, so here are some CDC recommendations in terms of having a successful and followed through appointment schedule for folks that are getting the double vaccine here, or the dual administration vaccine. So since the Moderna and Pfizer vaccines, they're administered with 2 doses, the CDC has provided guidance to increase provider success rate in fully vaccinating their patients. The CDC advises both doses of the series should be completed with the same product, citing the safety and efficacy of a mixed product series really hasn't been evaluated. A couple of strategies you can use to ensure that patients receive the second dose with the appropriate product and the appropriate interval between doses include making an appointment for the second dose before the recipient leaves. This will increase the likelihood that patients will present at the same vaccination site for the second dose. Providing your COVID-19 vaccine record cards to the recipient, and then asking the recipient to bring their card to the appointment for the second dose. It's also a good idea to encourage the recipients to make a backup copy. An example would be taking a picture of the card with their phone. Encouraging vaccine recipients to enroll in a free smartphone-based tool such as vSafe that uses text messaging and web surveys to provide personalized health check-ins as well as second dose reminders. So now let's talk about getting these claims paid for, billed and paid for these vaccines. So there's a couple of ways, and all of these providers listed on this slide here do have a couple of options. There is individual vaccine billing, so individual claims per vaccine per patient. You can also do roster billing, and roster billing is used when 5 or more patients are vaccinated in a day. You don't need to be necessarily a mass immunizer. You can actually be any one of these facility types, but you do need to enroll with Medicare in order to do roster billing. Okay, so here's some roster billing details. So there's a couple of paths here. So for Part A roster billing, what you would include is the roster template, and each one of your MACs that are out there, they do have their own individual template, which is easy to find on their websites. Do remember though that Part A, that is not something that you can bill by way of paper. And so if you're going to do roster billing for your inpatient or your Part A services, then you would need to manually key those in to your DDE system. Your type of bill will depend on your facility type, and then your revenue code should be the 771. And just a reminder that vaccines should be billed and are billed and reimbursed separately from your inpatient charges. So you're going to want to send a separate claim for that. For your Part B services, your physician, non-physician, and pharmacy, that one's going to be on a 1500. You can bill those by paper to CMS, and there is also a roster billing form that you do need to fill out. And like I mentioned earlier, you can find that form on your individual MAC. So for FQHCs and RHCs, you're going to submit the claim for your FQHC. You're going to submit that claim with the HCPCS, both for the COVID-19 vaccine and the administration. We've got our type of bill up here, as well as our administration revenue codes and your vaccine revenue codes. This is considered informational only because you will be reimbursed as an FQHC by way of the cost report, just like you do for your flu and your pneumococcal vaccine. For your rural health clinics, you're going to report this just on the cost report. No need to submit a separate claim for these, and the vaccine and administration will be based on reasonable cost by way of the cost report. The Social Security Act requires SNFs to bill for certain services, including vaccine administration, even when the SNFs rely on an outside vendor to perform the service. Therefore, in order to facilitate the efficient administration of COVID-19 vaccines to SNF residents, CMS will exercise enforcement discretion with respect to these statutory provisions, as well as any associated statutory references. So there's your kind of disclaimer there from CMS. So through this exercise of that discretion, CMS is going to allow Medicare enrolled immunizers, including but not limited to pharmacies working within the United States, to bill directly and receive direct reimbursement from the Medicare program for vaccinating Medicare skilled nursing facility residents. So here's some CMS vaccine billing tips. So fee-for-service is going to be handling all of the billing and reimbursement for the COVID-19 vaccine. And so even if the patient is enrolled in a managed care plan, you're going to want to bill that to the Medicare MAC, the fee-for-service, and you'll be receiving reimbursement from them. There is no patient cost share for the vaccine, and that also includes patients that are uninsured. You can reach out, and there are, through the state, there are some programs that you can bill to get reimbursed that way if you do have an uninsured patient. Be sure to just bill the administration only if you are receiving these vaccines that are federally funded. And I believe for now, most of the vaccines that we're seeing across the United States, they are still federally funded. And so you don't want to have that vaccine code on your claim. However, CMS, I did attend one of their webinars, and they did say rather hesitantly that they will allow the vaccine code on the claim if you want to put it on there for a penny, because it was expressed to them that it's going to be difficult getting it through the EDI system, having a administration on there without the drug. So they are okay with it, although it's not preferred to have that vaccine on there and just putting a penny on that charge. So let's dig a little bit deeper into some vaccine cost sharing. So you must administer the COVID-19 vaccine. This is per CMS here, and the CDC. There should be no out-of-pocket cost for the recipient. Providers are not allowed to deny anyone the vaccine based on their coverage status or network status. So if it's an out-of-network provider, they still should be providing that to the patient. You may not charge an office visit or another fee if the COVID-19 vaccine is the only medical service that's provided. It's just going to be just the vaccination charge. And you may not require additional medical services in order to receive the COVID-19 vaccine. So if a patient wants to be vaccinated, providers are not allowed to impose an E&M or a office visit first to see if they're eligible, for example, for the COVID-19 vaccine. So providers can seek appropriate reimbursement from a program or a plan that covers the COVID-19 vaccine fees, such as the private insurance company, Medicare or Medicaid. And then like this last bullet here, I just mentioned it earlier, there is a HRSA COVID-19 uninsured program for patients that do not have insurance that receive the vaccine at your organization. So that actually, last slide actually wraps up our vaccine information. And I did kind of slip this one in here. This was added pretty recently, but I just wanted to call out, this last slide is not related to telehealth or vaccines. Honestly, I think it's important though that we give this a quick mention. So at HRG, we have an internal notification process on any newly FDA approved services or products. This BioFire COVID-19 test hit our radar last month. As you know, during the pandemic, the theme is to get tested, and that all testing will be covered by federal, state, and commercial payers. The BioFire Respiratory Panel received their emergency use authorization back in May of last year, and the AMA published the CPT code 0202U with an effective date of May 20th of last year. So you fast forward until March of this year, and the FDA announces that the BioFire Respiratory Panel has now been granted marketing authorization. Great. It's important to note that this test is not covered under CMS, and each MAC has issued a local coverage determination advising the test is not covered. And unfortunately, most of our commercial payers are following suit. We've been seeing denials on this test for our clients for the past several weeks. And since there are specific clinical policies indicating no coverage, really, I mean, we're going to appeal these, but there is no recourse for most of these, and the amount of the test ultimately results in a write-off. I strongly recommend reviewing payer policies and communicating with your providers. And since payers aren't known for their consistency, I have included some keywords that you can use to search for medical policies on these particular payer websites. So on your commercial payer websites, here's some of the words that they use, and they've looped in this test. Some of them will include the title of BioFire Respiratory Panel. Others will not be that specific, but I highly encourage you to go out, research, make sure that the payers that you have contracts with, if it is a payable service or if they have a specific clinical policy that says that it's investigational, for example. Okay, so also included in our slide deck that Molly will be sending out later, we do have some resource links. All of the information that we talked about in our presentation today, we've got linked in here, including this fantastic AMA quick at a glance table here that gives you all the information that you need for the vaccines. So we have that link embedded in here.